Okay, well, good afternoon and welcome. I'm Dr. Larry Patterson. I'm the medical director of Eye Centers of Tennessee, founded it about 30 something years ago. And because this will come into play a little bit later, we're a general ophthalmology practice with my son is in practice with me. We've got another partner and three of us who do a lot of the ophthalmic surgery. We have about 10 optometrists, 10 or 11, who work alongside of us in about 9 locations. Today, we're going to be talking about Avellino, and we're going to discover something about Avogen, which is genetic eye test, and tell us a little bit about how that can help our practices like mine and yours, talking about keratoconus and family members and things like that. We have with us as our special guest, Dr. Mitch Ibach, who's an optometrist at Vance Thompson Vision. And Vance and I go way back. And I'm just going to go ahead and let him, Mitch, tell us a little bit about yourself and the practice setting you're in.
Yeah, I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota. We've grown to multiple locations now, but we're an ODMD collaborative care tertiary referral center. And so what that mouthful means is that optometry and ophthalmology referrals are really our lifeblood. That's, the majority of patients that we see, we take care of their anterior segment needs, which often includes surgery. And then we're collaborating with the optometrist or ophthalmologist who referred that patient to us. We do everything anterior segment surgical care. And so my practice is primarily cataracts, cornea, refractive surgery, and glaucoma.
Okay, great. As we go through here, if you're listening in, we would encourage you, if you've got comments you want to make on Facebook, LinkedIn, share your name, your practice name, let us know a little about you as well as any questions you may have for Dr. Ibach as we get going. And at the end, we should have a few minutes for Q&A. So let's go ahead and get started, because we're going to try to do this in about 20 minutes, not take up a lot of your time. So Mitch, just start out, tell us what is Avogen? How does it work?
Yeah, even before that, I'll kind of define keratoconus as this progressive or unstable ectatic corneal condition that can really lead to potentially blinding outcomes for our patients. And so in the last even 10 years, the diagnostic abilities that we have in keratoconus have really expanded. And one of our goals should all include diagnosing or catching these patients earlier and earlier. And so Avogen is an in-office cheek swab that gives us the patient's polygenic genetic risk score for keratoconus. And so we can do this cheek swab in office. It looks at 75 genes with over 1,000 variants, and then kind of adds up a patient's risk for developing keratoconus. Avogen also has a monogenic score and genetic test for some of our corneal dystrophies. But specifically for keratoconus, we're looking at kind of a wide swath of genes.
How did this all start in your practice? They developed the product, but what brought y'all into this? How did this all get started?
Yeah, and so we were involved very early with some of my partners, Dr. Vance Thompson, Dr. John Berdahl, and others with Avellino, and this idea of being able to do a better job screening or finding clues for keratoconic patients, as well as we're a big refractive surgery practice as well. And so specifically in keratoconus, I think we get these patients referred into our practice. Sometimes we have a patient who's maybe a keratoconus suspect, or they have a strong family history. We do a tomography, a corneal picture to look at the shape of the cornea. We look at the pachymetry, their refraction, all these other pieces. And then sometimes there's really borderline calls. And so having this diagnostic test can add a little bit more ammunition to either I'm more worried about this patient and we're going to see them sooner for their next follow-up to repeat some of this testing, or maybe I have a low genetic risk score for this patient and we can maybe stretch them out a little bit. And I think that helps ease the mind of some of our patients. And then being in a refractive surgery center, getting these patients referred in, we've all had borderline calls where we said, boy, this patient maybe has a mildly abnormal topography, or it's a bigger laser ablation, and we're going to leave them with less residual stromal bed. And can this patient have refractive surgery or not? Does it need to be PRK, or can it be LASIK, or does it need to be an implantable Collamer lens rather than PRK? And so in many cases, it can be the tiebreaker for some of these patients. And then finally, familial education. I think genetic testing as a whole is becoming much more popular now in 2020, 2021, 2022. There's all these different ways to get genetic testing done. And I think patients are asking about this specifically when there's a strong family history of keratoconus. They want to know, what's the risk of my son or daughter or my brother or sister?
So tell me a little bit about that. As far as genetic testing, your family dynamics, you've got a patient who has, let's say, full out keratoconus, or form for us just borderline keratoconus. Do you start talking to them about, I guess it depends on their age. If they're in their 20s or versus they're in their 30s, they have children, they have siblings. How far does this go? How does it work?
Yeah. Well, let me start by saying this isn't as simple as some of our other genetic conditions where it's maybe autosomal dominant and your son or daughter has a 50-50 chance of developing this condition, or it's autosomal recessive where they have a 25% chance. This is more adding up a patient's risk score. But in a lot of our landmark studies in keratoconus, and I'm a data guy, I love to dig into that, it's a little unclear what role genetics plays. And so some of them have a pretty low genetic risk or as a variable, and it's probably because of this is a piece to the puzzle. And so think of the genetics as one more piece for that patient, and it's maybe a genetic predisposition that gets activated by environmental stressors. And I think a big one for me is eye rubbing.
Right.
And so I think being an eye rubber is a risk factor for keratoconus. In my opinion, it's the number one modifiable risk factor, but maybe that is bringing on some of the genetic component as well. Or maybe that was a patient who had a strong genetic history, and now as an eye rubber, that could be the thing that pushes them kind of from that keratoconus suspect into full-on keratoconus. I think one of the more important studies, if you're talking about genetics and keratoconus, is a study by Dr. Rabinowitz, Dr. Wang, and colleagues, where they did a family aggregate study, meaning they looked at kind of the whole genome. And what that study found is if you had a first-degree family member, so mom, dad, brother, sister, son, or daughter, who had keratoconus, your risk was 3.3%, and which is about 5 times higher. You know, we're commonly saying now that keratoconus is somewhere between maybe 1 and 700 patients in some of the more recent articles. And that study said, it's 5 times higher if you have that first degree family member. And so I think that's where some of the counseling comes in.
And this has really hit home in our practice, because just in the last few months, we started doing corneal cross-linking. And this used to be a disease when I started in practice, and even 10, 15 years ago, someone had keratoconus there. You watched them and hoped it didn't get worse, or maybe you fit them with hard contact lenses, and eventually they made it a transplant. Now we're actually in a situation where if we can diagnose these things early, this is a disease that used to often lead to a corneal transplant that now is actually curable. At least, within quotes, it's curable, and you can stop it.
Yeah, I fully agree. And in fact, you took the words out of my mouth, or stole my phrase, or maybe I stole yours. But keratoconus just 10 years ago used to be a disease of just diagnosing, monitoring, patchworking the vision, and then crossing our fingers and praying that this patient didn't go on to needing corneal transplantation. But now with the advent of corneal cross-linking, these patients with progressive keratoconus or refractive surgery ectasia really need to be cross-linked. I think step number 1 is diagnosis. Step number 2 is arrest the disease progression. And then we can come back and use all these other tools to help them see better. And so I think, earlier diagnosis is really important, because the vision loss in keratoconus is fairly irreversible from a glasses and contact lenses standpoint.
So do you have any specific cases, something that comes to mind where using Avogen really made a difference?
Yeah, one of my more polarizing cases in my mind for keratoconus is a 14-year-old boy who traveled to see us. He was referred by his primary optometrist. That optometrist did a fantastic job of saying, you have some red flags for keratoconus, but I maybe can't make the definitive diagnosis here. And so this patient was referred in to our office. He was nervous. Mom was nervous. They visited Dr. Google before they came. And so they read the absolute worst possible outcomes that could happen with keratoconus. And after we diagnosed him with keratoconus, we got him cross-linked. We have him fit in a specialty contact lens in that eye. The second eye has since went on to keratoconus. And so remember that about 96% of keratoconus is bilateral. After we do our job of diagnosing and treating the first eye, don't forget about the second eye.
Mhm.
But then because of the way that his case was shaped, we caught him early. Mom and dad said, well, what about our daughter? Our daughter's 12. Can we get some testing done on her? And so we went through a myriad of tests for keratoconus, and we also did genetic testing for her. And luckily, her corneal tomography came back normal and her polygenic risk score was low. And so hopefully this gives that family a little bit of ease. It eases their mind a little bit. But I always stress to patients, just like other conditions like glaucoma, where if we're treating things, it doesn't mean that you couldn't progress. In keratoconus, if you have a low polygenic risk score, it doesn't mean that you still couldn't develop keratoconus. And so it's not a free pass to not see me for the next 5 years.
Well, briefly, and we talked about earlier, you and I both are in situations where we have ODs and MDs in the same practice. How does that work together? How have you implemented this? Who's really doing most of the lifting in your practice with this?
Yeah, we really, in my opinion, have a beautiful setup of optometry and ophthalmology working together at a really high level. And so the majority of the time, in fact, almost every time when we're having the discussion about diagnosis of keratoconus, making the recommendations of next steps, and when we're going to use Avogen on a patient, that's almost always kind of my discussion and education with a patient. And so bringing this technology on was really important to have a team approach where everyone agreed that this is important for our patients, and how are we going to deploy it in clinic to help us make both clinical and surgical decisions. And luckily, one thing that we all really strongly agree on is if we have refractive surgery patients and we're lowering the risk of having refractive surgery ectasia, which is very, very rare, but we take that number even lower by adding this for some of these borderline patients. That was an easy, let's get on board for everyone.
So do you have a person who's the Avogen person in your practice who basically you see someone, you see a need or a family member with a need and you go, this is who you need to see? How does that work?
Yeah, whenever we bring on a new technology in our practice, we like to have a person or two who is the champion of that technology. And for us, that's usually our nurses and technicians. Boy, they really make sure that our lives are easy as doctors, and they're kind of the Navy SEALs on the front line doing the really hard work. And so we have them be experts on the technology, if you will. And so we had two champions of Avogen when we brought it on, kind of for each doctor team. We have a couple different doctor teams, but those champions would then be the ones that were responsible for giving the test or administering the test to patients. They were responsible for correctly, putting the swab back in the vial, shaking it correctly, ultimately sending it off through the portal, and then watching the results. And so watching for those results to come back in so that one of our doctors could then make the call and do the patient education afterwards.
Just run us briefly through the swabbing and what exactly happens. How long does it take? What happens? Yeah. Results, things like that.
Yeah, in the test kit, it comes with 4 swabs, 2 different kind of vials of solution. And so we'll use 2 swabs to do on the right cheek. And you want to have not a painful swab, but you want to have an aggressive swabbing to make sure that you get enough of the genetic material or DNA from that swab. And so we're swabbing the right side twice, kind of putting it into the vial. You want to make sure you bring the vial up and down a couple times, putting the cap on, do the same thing, kind of rinse and repeat for the left eye. And then we're signing it up through the portal, sending it off to Avellino. And then I expect about a 2-week time frame. Once we get that set off, I'm hoping to see the results in about 2 weeks. Those results can get faxed back to you. We can, call on those results as well. And you get a really nice printout that kind of walks you through some of the common gene traits and then maybe some of the more obscure gene traits, some of the ones that have a very high significance for certain conditions. And then one of our doctors is going to call the patient and kind of walk them through the results.
So you usually let the patient know about this by phone. And so you're not getting results and saying, you're just giving them a rough idea of what the chances are that they may develop keratoconus and that sort of thing.
Yeah, I think it's really important that the doctor has a baseline knowledge of the test that we're ordering and then how to review the results. And so with Avogen, you get kind of a 0 to 100 score. It's broken down and kind of color coded for us, which as doctors is really nice because we're getting used to kind of the stoplight grading of green is good, Yellow means slow down and red means stop. And it's a similar idea here, but I don't get into the weeds too much talking with patients that your individual score is a 28. I kind of break it down into you have a mild risk, a moderate risk, and an advanced risk of developing keratoconus. But again, I just want to reiterate, having a advanced or high risk doesn't mean that the patient has keratoconus. This is not a standalone diagnostic. It's rather just adding in a little bit more strength to our belief or our argument of what we thought the other testing was telling us.
I had a patient, a friend of mine years ago, and we were getting ready to do LASIK on him. And man, we looked at the topography really carefully, and it was just sort of, it wasn't keratoconus, but it made me uncomfortable. And do you have people like that who you might use this to wonder if they're more likely to progress in the future?
Yeah, that's a great question and kind of a funny way to analyze it, but I think you're exactly right. It helps our patients. I think it can ease their anxiety. But as doctors who are either recommending surgery or performing surgery, when something just doesn't add up, having a tiebreaker like this can help your patient sleep better at night, but it can help us as doctors sleep better at night too. And we can say, we did everything we could. We used every test. We used all these different in-office technologies. We did your genetic testing. And sometimes it still comes back where maybe that patient has ectasia, but we did everything we could to try to prevent that. And the same goes for keratoconus. We did all of these different things. You know, we're spoiled now in 2022 with corneal tomography and epithelial mapping and tachymetry and an in-office cheek swab to look at their genetic risk, where if we want to have an all-encompassing approach to make this diagnosis, we can.
And in general, what's the patient reaction to this? How do they take all this information?
Yeah, I think it's always easiest if you're not first, and Avogen kind of wasn't first into the genetic testing market. And so patients are familiar with things like 23andMe and the other ones to get genetic testing. There's now different testing to see how foods affect you. And so it's becoming more and more common. And I think now we have different generations of patients who are very interested in stuff like this. And so I think it's been really good. I think patients are very comfortable. There's no pain for them, and they get to know more about their body's risk.
Yeah, it's funny. Right before we came on, I did 23andMe a couple years ago, and I'm still getting reports. And I just got a report that says I'm 66% likely to be comfortable speaking in public. So here we are.
Yeah.
Well, let's we've kind of breezed through this. Let's see. Do we have any questions at this point?
Yeah, we do have a question that came in from the audience on Avogen having resources for patients if there is a high genetic risk. And there is things that Avellino offers as far as resources for patients. There's lots of resources on the internet for keratoconus as well. A couple of the ones would be the National Keratoconus Foundation. Living with Keratoconus is another one. And so there are lots of resources that's specifically talking about keratoconus risk, but Avellino can help in this arena as well.
All right. Well, with that, I think we'll conclude. We've pulled up about 20 minutes worth of time, and we appreciate your audience, our audience being here. Appreciate your time, Mitch. And I just want to really stress to everyone watching, if you have any questions about this, just reach out to Avogen. They'll be very happy to take your questions and see how you and your practice could see about getting set up in this. Any concluding thoughts?
No, I think this is another tool to have in your armamentarium. If you're a practice that is embracing new technologies and you want to have another tiebreaker device in the keratoconus and refractive surgery space, I think this can be really helpful.
All right. Well, I'm excited to hear about this. And with that, we want to thank you for your attention, and call us if you have any questions. Thanks.
Thanks, everyone, for joining.